Good morning, everyone. So we have a very special treat this morning. Dr. Lola Fayanju is visiting us from the University of Pennsylvania, and she is delivering a lecture towards a better version of our surgical selves. And this is a very, very timely topic. You know, a lot has changed, I think, in the last year and a half or so, given all the politics. But despite all the politics, really the core issues and the problems have not changed. And I believe, it's my personal opinion, that if we build a department of surgery, research programs, and we participate in research that reflects the population that we take care of, we're a much better department, much better institution, and our science is stronger, right? And that issue is not going away, and we're going to hear a lot about it. And although we have to tackle this, I think, in a different way, it's still very important to tackle, address, help solve, and make sure that every Coloradan, every American has good access to healthcare, appropriate education, appropriate leadership opportunities, say in a department of surgery or in an institution. Dr. Washington, I want to thank you for all you've done over the last years, and also for helping us to pivot and still address the issues in a way that we can, and to still make forward progress. I'm going to invite you up to introduce our very distinguished guests. Dr. Washington, thank you.
Hello, good morning, everyone. It is my great pleasure to present Dr. Fayanju. She is the Helen O. Dickens Presidential Professor in the Perelman School of Medicine at the University of Pennsylvania and Chief of the Division of Breast Surgery for Penn Medicine. She is also the Surgical Director of the Rayna Rowan Breast Center in the Abramson Cancer Center, and Director for Implementation Innovation in the Penn Center for the Cancer Center, Cancer Care Innovation, and Senior Fellow in the Leonard Davis Institute of Health Economics. So she's surely an underachiever here. She received an AB in History and Science and an AM in Comparative Literature from Harvard. She received her MD and MPHS from Washington University in St. Louis, where she also completed a residency in general surgery. She completed a fellowship in breast surgical oncology at the University of Texas, MD Anderson Cancer Center. So it's really a great honor to have her today, to have someone with her level of expertise and knowledge and experience, and I want to welcome her here today. Thank you.
Thank you for the warm welcome. Can everyone hear me okay? All right. Well, again, thank you so much for welcoming me to the Mile High City. I had the pleasure of spending yesterday with Dr. Lauren Stewart, my longtime friend and godmother of my younger son. Those of us who were in the trenches, I call residency a crucible in which you're kind of co-forged with your co-residents. And so again, very grateful to come and see the city she's embraced, the institution she's very proud of. And again, thank you very much for having me. So the title of my talk is Towards a Better Version of Our Surgical Selves. And I think it's an important aspiration because often surgery, this work that we've chosen, asks so much of us that it's hard to bring our best selves to all aspects of our lives. Where's the keyboard? I'll use that. So. There we are. These are my disclosures. I want to begin with an anecdote. About 5 years ago, my family and I went to Philadelphia as my husband and I were weighing the option of moving from Duke to Penn, where we now are. And this building is the Inn at Penn, which is the kind of equivalent to the Benson Hotel I stayed at last night. A lot of faculty stay there, a lot of visiting professors stay there, as well as people who are considering employment. And you have to understand, this was the first trip that my family had taken since COVID had swept across the world. And my children, 9 and 7, wanted to touch everything on the plane. And I was very distracted by the fact that this is the first time, again, pre-vaccines, that we were going somewhere, and it was a lot of logistical coordination. And we got in very late at night and just went straight to bed. The next morning, we got up and we went outside. And after stepping around and looking around a little bit, my older son, Toby, looked around and asked me, "Is there a lot of crime here?" I will admit I was a little taken aback. Granted, we were coming from the rather bucolic settings of Chapel Hill, North Carolina, where we had deer, crossing our front yard, and we spent many of our afternoons in the woods fishing, especially during that lonely period of isolation during COVID. And I tried to think about what it was that he saw around the Inn at Penn that made him wonder if there was crime there. There are a couple of individuals walking rather aimlessly nearby, both Black, both carrying what appeared to be all their worldly belongings on their backs. And in the background was the din of the city, but otherwise nothing that should make my admittedly rather worldly 5-year-old, 9-year-old feel unsafe, and yet he did. Is there a lot of crime here? How do you answer that about Philadelphia, the city of brotherly love? So Philly is very proud of the many things that it's first at. It's the 6th largest city in the United States, but once upon a time it was the largest up until 1790. Obviously home of, many people think of as the birth of America, the cradle of our country, where all these events took place. We have the claim of the first hospital, the first medical school, and 1/6 of the doctors in the United States trained at some point in Philadelphia. We also have the largest collection of public art, as well as the oldest continuously running English language theater in the world. At the same time, Philadelphia, like many other cities across the United States, has experienced population decline as people fled the urban areas for the suburbs. And the biggest decline, not surprisingly, was amongst the white residents of Philadelphia. Up until literally last week, it was the poorest large city in the United States. That title has now been claimed by Houston. 23% of residents live in poverty. 40% of Latinos in the city live in poverty. And you can see that there are huge disparities in terms of how much people of color make and how much their household income is relative to the majority white population. 1/3 of high school students in the city of Philadelphia do not graduate. And you can see that employment, which was significantly hampered by the COVID, has not yet rebounded. And unfortunately is the #1 city with regards to violent crime in the United States amongst the top 10 cities. Now, this can all be true, just as the things I saw about the history of Philadelphia can also be true, and the fact that you have some of the wealthiest people in the United States living in the same area. But the reality is that the geography of violence, which my son somehow intuited, and which is really embodied by the fact that Philadelphia, specifically the University of Pennsylvania, is right at the border of some of the most gentrified and wealthy areas and some of the poorest and most violent areas. And we know that there is a concentration of violence in disinvested neighborhoods. Within these neighborhoods, violence is even more concentrated within these microgeographic places, particular streets that can really change the difference whether you're likely to be shot or killed as compared to walking one street over. So we know that the geography of violence is such that it is not developed in a vacuum, and it is bred and nurtured by policies that may be indifferent to the local population at best and cynical at worst. And the question is, what role do we surgeons have in shaping the worlds in which we live, in which we practice care, in which we hopefully can achieve the best outcomes for the patients we're privileged to serve? Today, I'm going to talk about that, thinking about what our obligation is to shape the world in which we deliver care, conduct research, and grow the next generation of physicians and investigators. But I want to begin with some definitions. First of all, what is a health disparity? I think it's important to realize that disparity is not simply a difference. It is actually an observable but also avoidable difference. The idea that this is something that we see between groups, between populations, that is rooted in what is unjust and ideally should be avoided with appropriate implementation of policy, and distribution of resources. On the flip side, what is health equity? It is the distribution of health according to clinical need. That is, there should be equal opportunity for all people with the same conditions to use and access healthcare resources that they need. But as you can see, if you think of disparity and equity as opposite sides of the same coin, one that is ultimately flipped by whether you believe that justice is being served or not, we actually have to also have a common view of justice. And increasingly in the United States, that is not the case. What is diversity? It can be many things, the state of having variety, mixture, difference, mélange, heterogeneity. And for a long time, I think we've maybe rather glibly said diversity is something that's good for its own sake. But I would argue that it is something that is worth having because it actually informs the way in which we can do better science and practice better clinical care. But that is, again, something that we may not always all agree on. And so you have to keep that in mind as you talk about the issues surrounding diversity and whether it's sufficiently promoted. And then finally, I want to talk about representativeness and representation. So Hannah Pitkin is a political philosopher who is most known for her concept in the 1960s on idea of representation. Specifically, what does it mean to represent a larger group? So there's the idea that you could have representatives resembling a larger group. Think of It's a Small World After All from Disney. That's the microcosm you see up there. And then there's the idea that as a representative, you advocate for the interests of a larger group. And you can think of that, or of an individual, you can think of that as like a court-appointed designee for someone who doesn't have the ability to make decisions for themselves. And then there's the idea of delegates, that is, you advocate for the preferences of the masses. And that, you would say, is what our politicians are supposed to do. Now, we as surgeons, I would argue, have to be representative of many of the different things, or sometimes are called to be representative of many different things in our world, in our profession, for our patients. And I guess one question is, at what point or to what extent do we exist at the intersection of these three different forms of representation? And more importantly, do we think we belong there? I would argue that we do, and I want to talk about that with regards to how we deliver care. So I'm a breast surgical oncologist, and so I'm going to begin by just speaking about what breast cancer is. As many of you know, it's the most common non-skin cancer in women in the United States, and 1 in 8 women will be diagnosed in her lifetime. I will also say that rates of diagnosis, particularly among younger women, appear to be going up. There are approximately 300,000 new cases of invasive breast cancer and 60,000 cases of DCIS diagnosed in US women every year, and the leading risk factor is simply being a woman. But men can get breast cancer too, and here I have as an example Matthew Knowles, the father of multi-hyphenate Beyonce, who actually has BRCA2 and was diagnosed with breast cancer several years ago and has brought a lot of publicity to the concept of male breast cancer and the importance of men being aware of being diagnosed with it and then getting genetic testing if they're diagnosed. However, despite the fact that we know about these famous genes, whether it's Angelina Jolie or others talking about that, most people who get breast cancer have no family history. And even having a first-degree relative with breast cancer only doubles your risk. It's not something astronomical. About 5 to 10% of breast cancers are genetic, and overall, people do really, really well with breast cancer, with a survival rate of greater than 95% for early stage 0 or 1 cancer. But it is not a universally positive story. And we know that while white women have the highest rates of breast cancer diagnosis in the United States, Black women have the highest rates of death. We're more likely to be diagnosed before 40, that is before routine mammography begins. And we're more likely to die from breast cancer at every age at which we're diagnosed. Hispanic women have improved overall survival actually compared to almost every other racial and ethnic group, but are more likely to be diagnosed with lymph node involvement at presentation and also have longer time to surgery, which means they're more likely to not only have and need more aggressive treatments, but also longer to live with the sequelae of that aggressive treatment. So they have more working years in which they have to manage lymphedema and neuropathy and deal with the fact that they've been forever changed by a breast cancer diagnosis. When you look at women who are of Asian and Pacific Islander ancestry, they have lower rates of death compared to white, Black, and Hispanic patients in the United States. But notably, immigration significantly increases the relative risk of breast cancer diagnosis in this group by as much as 6-fold. And the categorization of Asian belies the granularity of this group that hails from the largest continent on Earth. Work that we've done has actually shown that women of Southeast Asian ancestry in the United States are at particularly increased risk for HER2-positive disease and often have outcomes that are comparable to those of Black women with more aggressive cancers. And the disparities that we observe in the United States can also be seen across the globe, where there is insufficient correlation between how often breast cancer is diagnosed and how likely you are to die from it. As you can see in developed countries, including USA, Australia, and New Zealand, there is very, very good survival akin to what I described before. But you can see that in South Africa, despite the fact that this diagnosis and incidence is relatively low, survival is very poor. But again, it is disheartening to see that once you look at breaking down the population in the United States between white and Black patients, suddenly we look much closer, not hugely close, but closer than we should to a country that has really very few resources to treat patients the way they should for breast cancer. And that's something that we should really not be proud of. Now, when people think about why patients have disparities and why is that certain groups do worse, I think a lot of people want to turn to biology. Even the average person in medicine will say, oh, it's because Black women have more triple negative breast cancer, which is a more aggressive variant that is granted more likely to be diagnosed in people of African ancestry. But I think it's a slightly lazy and easy thing to say that biology is what's driving these differences. As I mentioned, disparity is about what is unjustly different, not what is fundamentally different. And if you want to say, okay, well, they're just more likely to have aggressive disease, I will posit for you the fact that P53, a tumor suppressor gene that's commonly mutated in many cancers, is more commonly found in the cancers of Black women, but it is also more commonly found in patients with low SES across the world, in geography areas that are as different as the South Side of Chicago and Dundee, Scotland. Furthermore, even though triple negative breast cancer is more common in Black and Hispanic women, if you actually can ensure that guideline concordant care is received, you no longer see a survival disparity. Black women are actually more likely to die of the cancer that we treat the best, that is cancers that are fed by estrogen and progesterone. And so it is very, very important to realize the disparity in mortality that's observed is often amongst the most curable cancers, and that 50% of the Black-white mortality difference could be attributed to suboptimal treatment. Triple negative breast cancer disparities are explained by suboptimal treatment and surgery, though the biology, therefore, is an easy but inappropriate scapegoat. I will admit, however, that too much time has been spent in the world of studying disparities, focusing on things we can't change. We can't change race, we can't change income, we can't change education level. And there's been much less successful translation of knowledge into outcomes-oriented action. And that is where I think we as surgeons, we're doers, can actually play an important role. The subject of my K award was the idea that what we really need to focus on in addressing disparities in breast cancer is modifiable risk factors, opportunities for change and intervention that go beyond and across demography. Lifting all boats will also lift the boats that are the lowest on the tide. And my hypothesis was that dynamic modifiable risk factors significantly contribute to disparities in breast cancer, as I've already mentioned. And if we address these factors, even if we don't share a common vision of justice, we do have a common commitment to making that sure that we don't have high costs attributable to preventable recurrence and death. And so the idea was that if we could address these outcomes, we could decrease system-wide costs and also improve outcomes. That's something we can hopefully all rally around. Now, one of the reasons it's hard to address disparities is that often disparities researchers don't sufficiently, or it's hard to capture the patient perspective. As I mentioned, it's often caused by avoidable or preventable circumstances, but numbers don't always tell us everything. Critical to addressing disparities is the need to get the patient perspective. That can be done through less conventional forms of research, including interviews and focus groups in the qualitative realm, but also through patient-reported outcomes. So patient-reported outcomes are measures that go beyond traditional metrics of disease morbidity and treatment efficacy. They are the idea of communicating the patient experience without the filter of clinician interpretation. And if we can examine patient-reported outcomes across a cohort, we can sometimes reveal otherwise unmeasured differences and opportunities for improvement and redressing of disparities. During my time at Duke, I examined patient-reported outcomes across women who are presenting with breast cancer diagnoses over a 2-year period. And specifically, we wanted to look at something called distress, which is a psychosocial sensation that's experienced by people throughout life, but is typically heightened during a cancer diagnosis. And the NCCN distress thermometer, which some of you may be aware of, is actually a very short patient-reported outcome measure that allows us to track distress over time, in addition to how people are doing when they first present. At Duke, we actually administered this to every single appointment where patients were seen, except when they were on radiation treatment, because that was basically every single day. What we found by looking at 1,000 women and nearly 13,000 visits was that distress increased over time for women who were unmarried and women who had Medicaid. For most people, it went down. We also found that on a scale of 0 to 10, 0 meaning no distress, 10 meaning extreme distress, that the median score was 4. However, Black patients reported lower baseline scores, so they were less likely to report a score of 4. In addition, they experienced less improvement in distress over time. And we sought to figure out why that was. So we did a deep dive into what was happening at that very first visit. That is the first time we're seeing someone after they've been diagnosed with breast cancer. What we found is that our Asian and Hispanic patients had the highest median distress scores of 5, so above this threshold of 4. And I want to emphasize that that 4 level is actually very important in our clinical practice, because through much research done actually throughout the world, including in Europe, where they have a very robust nursing-led approach to patient-reported outcomes, 4 has been the number we've coalesced around as a threshold above which people have clinically significant distress, that is distress that might prevent them from presenting for care or pursuing treatment, and for above which our nurses at Duke were actually empowered to just call a social work consult. They didn't need to come to the physician for that. We found again that Black patients had the lowest median distress score. We found that various stressors, so emotional stressors such as pain, emotional stressors such as anxiety, physical stressors such as pain, practical stressors such as challenges with childcare were associated with increased distress. Again, we found that Black patients were more likely to report no distress than white patients. And that's despite the fact that they were also the only group that had a referral that was lower than this threshold for 4. However, what we found is when we did a deep dive into the number of stressors and the type of stressors being reported, Black patients reported the same number of stressors, just the same. Yet they were ascribing to themselves a lower level of distress. So that tells us that even though this is a very well-vetted and very widely utilized instrument used across the world, perhaps we are under-capturing the experience of individuals who actually need help and need support, but won't get it because the cancer diagnosis is happening in the context of an already stressed and stressful life. We wanted to see what the impact of this distress actually was on time to evaluation and time to treatment, with recognition that in breast cancer, we know that there's actually worse survival if time to treatment is delayed by more than about 60 days. And what we found is that for patients who were Black, who were divorced, who had practical stressors, physical stressors, and particularly if you were Hispanic and had a practical stressor, you were more likely to have a delay from time of diagnosis to being evaluated for the first time after diagnosis. Furthermore, if you were Black, had practical stressors, presented with higher stage disease, or Hispanic and had practical stressors, you were more likely to have a delay in diagnosis to treatment. So what does this tell us? This is information we gleaned from our very first visit. It tells us that often the path towards worse outcomes and a disparity that's potentially preventable is already set at the time someone presents for their first visit. The die has already been cast, which tells us we need to begin sooner. So what now? And why us as surgeons? I think that we surgeons are often important information gatekeepers at key inflection points during patients' lives. I think all of you have experienced at some point the disclosure that can happen in the trauma bay. When someone knows that their life is at stake, it's amazing the things that they're suddenly willing to reveal. As a cancer doctor, I've often been privy to things that they have told no one else when I'm telling them about their diagnosis. And as a result, I think we have an opportunity, indeed an obligation, to act on the vulnerability of our patients at that moment in time and potentially translate their willingness to talk with us and open up to us into helping improve the trajectory of care that they begin on. So to that end, I actually think that it's really important for us to collect and intervene upon modifiable contributors to disparity that are often revealed to us by our patients in these moments of need when they present for surgical care. All of you will have heard of social determinants of health, but I also want to include behavioral determinants of health, which are the conditions in which we live, work, and age. They have implications for our access to healthcare and ability to achieve favorable outcomes. They are really community level factors that kind of constitute the milieu in which our patients are consuming healthcare and which we practice it. Related to that are what we call health-related social needs, which are individual level factors that are related to social and behavioral determinants of health and also affect individuals' abilities to maintain health and consume healthcare. Examples of that include lack of stable or affordable housing utilities, financial strain, lack of access to healthy food, ongoing threats to personal safety, or inability to access care through transportation. Now, as the COVID pandemic actually demonstrated, we know that social determinants of health can have an outsized effect on our ability to have good outcomes. Much of the death that we saw in the COVID pandemic was completely preventable and related to the fact that people couldn't isolate at home, that they couldn't avoid going to work, that they couldn't take the measures and means to protect themselves during this time of global pandemic. But the truth of the matter is we all know that we're really, really bad at collecting this information. We don't have time to fit that into a 30-minute new patient consult. There are high rates of missingness and misinformation in the social history data in our EHRs. And also, who's going to collect this data? Do we have time for this? Do our nurses have time for this? There are temporal and financial pressures in the outpatient, primary, and specialty care setting that doesn't really allow us to do this well. Also, should we do it? Should our patients do it? Should they use the portal? Should our nurses do it? Do we do it on patient paper and pencil? Do we do it through the electronically or hybrid? And then how often do we collect this data? How often do we scrub it and make sure it's still correct? We're not necessarily getting this like vital signs every single time a person presents. So what triggers it? Is it an event? Is it a procedure? Is it that we screen everybody all the time? And then do we collect this information at home or in a healthcare setting? And then finally, in this era of open science and increased concerns about privacy, who does this data belong to? And what do we do with it? All of these considerations prompted a clinical trial that we launched and that we've recently concluded that looked at whether or not we could do a better job at capturing this information very, very early in a patient's cancer course. That is basically as soon as they're diagnosed. And the goal of our study was to identify the optimal combination of modality as well as instrument to facilitate SBDOH collection at time of diagnosis amongst diverse patients. We wanted to compare rates between different types of data collection instruments and also see whether there are differences depending on when a patient used the patient portal, they used text messaging, or if we used a voice response program, and then assess time to evaluation as a result. We are now in the part of the study where we're looking at qualitative analysis to see what were the mechanisms that facilitated patients either joining the study, participating fully, or agreeing not to do it. Here's a schematic demonstrating how we enroll patients. So when a patient was referred for oncologic evaluation to our new patient office, they were then randomized to one of these 3 instruments as part of an opt-out study. One of these is the Accountable Health Community's Health-Related Social Needs Screener, which is advocated for by CMS. The other is Health Leads, which is run by a not-for-profit organization that used to be called Project Health. And then the other is the NCCN Distress Thermometer for Problem List. We came to the consensus about using these 3 instruments after a university-wide and also externally informed discovery workshop where we had experts in psychometrics and social determinants of health and social work come and meet with us and think through which of these instruments would be most appropriate to trial as part of an investigation. Patients were randomized to one of these 3 instruments. And the first thing that happened is that they were sent this instrument through the patient portal, recognizing that, we know that most people use the portal, or that's at least the most default way in which we communicate with patients these days. But also recognizing that there are known disparities in terms of who uses the patient portal and how often they engage with it. We also made it available to patients, if they didn't respond within 48 hours, either the option of being randomized to a text messaging interaction or getting this through a voice response where you press 1, press 2, et cetera, to respond to answers or questions that are posited. And then if we didn't get them to answer by the time of their first visit, we actually met them at the door of their new patient visit and encountered them in the waiting room, provided an iPad, and encouraged them to complete this. So it was a very high touch approach to trying to collect this information. So we are actually going to be presenting this, the data as the full findings of our trial at the ASCO Quality Care Conference that is occurring in October in Chicago, not long after the American College of Surgeons. But I wanted to share with you some of our preliminary data that we actually presented at the Academic Surgical Congress earlier this year. So amongst the first 100 trial eligible patients, again, this is an opt-out study, and we had quite high rates of participation. We were pleased to see that there was actually quite a lot of diversity in terms of who decided to participate, or rather didn't opt out. It reflected very much our population served at Penn. 56 patients completed an instrument. What we found, however, is that none of the eligible patients with less than a high school degree completed an instrument. We also found that the people who were most likely to complete an instrument were those who had actually gone to grad school or more. With regards to income, of the 11 eligible patients with income less than $50,000, only 3 completed an instrument. And again, of those with incomes greater than $100,000, we had, almost 2/3 of them complete instruments. We were again pleased to see there was no differences in completion by race, ethnicity, marital status, or insurance. However, it was very striking to realize that amongst trial eligible patients, those with the least education and lowest incomes were also the least likely to successfully complete this screen, despite the high touch resource rich setting in which we were doing this. So of course, what that tells us is that we aren't necessarily capturing the people we want to capture, even though we know this is super important, even though we tried really hard to do it. And what that really brings home is that collecting this kind of data, while important, it can help us be a better doctor. Doing so requires exceptional creativity, flexibility, and intentionality. This can't happen by accident, but it's incredibly critical to our being the best version of our surgical cells and providing the best care for our patients. Now, how do we think about this with regards to how we conduct research? So, first of all, sometimes I have to spend time just explaining to people why there's a problem with regards to health disparities and why it's something we should study. So, among clinical trials, I want to again emphasize that we have real underrepresentation of people of color relative to the representation in the population. While African Americans and Hispanic patients constitute about 15% of the population, they constitute a much smaller proportion of those who participate in clinical trials. And what's important to know is this underrepresentation happens even in cancers that have a higher prevalence in people of color, such as multiple myeloma or aggressive prostate cancer. Notably, African American and Latinx patients are also overrepresented in phase 1 trials, but underrepresented in phase 3 trials. So you'll all recall, phase 1 trials are those that are first in human, where we're basically just testing the safety of an investigational drug. While phase 3 trials are the ones that actually have the best chance of your deriving personal benefit from that trial. But often those are also the ones with the greatest number of exclusion criteria, performance status requirements. That is, these are the trials where people are most likely to derive benefit and have the least risk to themselves. And those are precisely the trials where we're less likely to see people of color. We also found that African American patients are more likely to participate in trials that do not require informed consent, the kinds that occur when someone's in extremis in a trauma bay, et cetera. So again, we really have to think about what are we doing with regards to how we're conducting clinical trials? What does the consent process look like by phase? Are we selling a song to patients who are in phase 1 trials, knowing that often those are patients who are, yes, healthy volunteers and may be excited to get some money as part of participating, but also often are stage 4 patients, where this is their last chance of getting something that might be the miracle that saves them from death? Are we potentially exploiting the concepts of therapeutic misconception? That is, patients don't fully understand why they're getting into research. And are we failing to adequately convey the goals of phase 1 studies? And are we engaged in enrollment bias with regards to phase 3 studies? Now, back in 1993, which appears to be a bygone era of bipartisan collaboration, Congress passed the NIH Revitalization Act. The idea being to encourage participation of women and racial and ethnic minority patients in NIH-sponsored research. And a group out of the Mayo Clinic conducted a review about 25 years later, looking to see had there been any actual important impact. And what they found was that unfortunately, they saw that racial and ethnic minorities continue to be underrepresented across almost all disease sites, with the exception of breast cancer. So we were kind of proud about that. We saw near equal participation. However, their study did not include surgical oncology trials, that is, trials that required surgery as a requirement for participation, or where the surgery itself was the object of intervention and investigation. So we decided to look at that. We performed a case control study examining disparities in clinical trial participation across breast surgical oncology patients, comparing those who were trial eligible in the National Cancer Database to those who actually participate in trials in the Cancer Therapeutic Evaluation Program of the NIH. And what we found is that participation actually declined across all racial and ethnic groups over time. You might think about, well, why would that be? 40 years ago, breast cancer was just one thing. And if you enrolled in a breast cancer trial, all you had to have was breast cancer. But as our understanding of breast cancer has become ever more sophisticated, we now know that breast cancer is actually a constellation of heterogeneous diseases occupying a shared anatomic space. And so increasingly, your opportunity to participate in a trial is very limited because it has to be based on your subtype of disease, your stage of disease, a particular receptor or biomarker that's present in the cancer. And so basically, it is harder now to enroll patients in trial than it was 40 years ago because the trials are increasingly now with regards to their eligibility criteria, which means we have to be increasingly intentional. We did find that Black patients were less likely to participate than white patients, but we also found an interesting interaction between income and race and ethnicity. Our high-income Black patients were 50% less likely to participate than our lower-income Black patients. And that's important because too often we want to ascribe racial and ethnic disparities to a lack of income or resources on the part of minoritized individuals. What this really highlights is that it's at our peril to assume we know why people aren't participating in clinical trials. And indeed, what we need to do is have a diverse array of interventions that reflect the heterogeneity within racial and ethnic groups, and not just between racial and ethnic groups, to facilitate equitable trial participation. The goal is to make sure people know they have a choice, and to make sure that we also address the concerns of both people who are very well resourced and who frankly are very aware of the history of discrimination in this country, and therefore are not going to take the chance of leaving their care to randomization. Future trials also increasingly need to focus on the biology-driven, subtype-specific, clinician-informed inclusion criteria that I've already mentioned. And if we don't do so, again, it's at our peril because we will have a less good understanding of diseases that are currently most common in certain groups. We will understand less well how to do triple-negative breast cancer treatment. We'll understand less well how to understand HER2-positive breast cancer treatment if we don't prioritize over-enrollment in some cases of Black and Southeast Asian women, respectively, for example. And it all comes down to, are those groups and are those diseases being prioritized in our research? Who is at the table when decisions about research, both the funding of research, the subject of research, and who's in the research are being made? It is really hard to do health disparities research. I will tell you that my H-index is driven much more by the work I do that is not related to disparities in health equity than the work that's related to disparities in health equity. And that is because people tend to cite each other. People only talk about differences in disparities if it is the actual subject of the work versus something that should be pervasive in all the work we do in trying to improve outcomes. One, we have a hard time defining what is disparity, what is equity. We're not always agreed on what justice looks like. Scale is hard. If we're dealing with a disease where there are very few people who get it, and if we know that the people who get it are already part of a minority group, and it's very hard to get those minoritized people into trials, we're less likely to have the sufficient power to detect a difference when we're trying to compare two different interventions. We often have conflicting stakeholder priorities. What researchers want, what funding agencies want, what patients want are not always the same. Sometimes we need to use non-traditional methods, such as the qualitative methods I've already mentioned, patient-reported outcomes, for example. In addition, we need to be very intentional about incorporating a desire to understand and redress disparity into our development of research at inception versus just looking for an interesting p-value after we run all the numbers. As I've already mentioned, there may be an adequate reward for being a health disparities researcher at a time when, in fact, it may feel that you're kind of being targeted for prioritizing that work. And as I've already mentioned, it is not necessarily the work that drives H indices and citations or clicks. I will also argue that we don't know what we don't know. And too often, if you tell someone something, they are surprised that there are disparities in certain diseases in certain groups. And they also may not have the curiosity to know why that is and how we can do better. But we have to. One, conceptual blind spots lead to poor study design. Too often, we don't realize that a drug is not going to work well on a person, or that a particular intervention or surgery is not going to work well in a particular group because they are underrepresented in the trials in which that was designed. Generalizability, of course, will then be an issue. Things that we've seen in other types of work, looking at the adequacy of different medications and whether they were sufficiently comparably adequate in people of different sexes, for example. There's the danger of using race and ethnicity as a proxy for genetic variation. We know that race and ethnicity is a social construct. And again, it is a danger to us if we dare to think that using race is really the way to talk about people's genetic ancestry. They're not the same. And there's too much that goes into looking at race to use that as quite an equivalent. We also know, as I've already mentioned from the basis of my work, disparate treatment leads to worse outcomes and higher costs, which we really cannot afford as a society, especially as our demographic makeup in the United States is rapidly changing. It is changing while sometimes our leaders are not even aware that that changes. All of us want to know how to treat patients as well as we can, and all of us want to do that. And none of us, I think, wants to do the kind of medicine that only works well for certain groups. And so I think the basis of being a great doctor is wanting to do as well as you can for as many people as possible, which means you have to prioritize having diverse individuals in the work that we're doing and making sure their outcomes are as good as they can be. And then finally, research priorities wax and wane, as we are all too aware. And sometimes we have people who are chasing the ability to get funding more than the topics that are being funded. And so you see this ebb and flow in terms of what is sexy at any given moment and what is the priority of people who are good at writing grants. And that's really where their focus of work is. And the real challenge is that right now, when the eye is taken off the ball of research that focuses on already marginalized groups, there can be a backslide and a risk of non-recovery that really will not be redressed even if that funding ultimately is restored at a later time. Ways in which we can do better. When you are doing research, you can be someone who's active in redressing disparities just by virtue of being an investigator. You want to be thinking about diversity at design, deployment, and dissemination. Think about who are your collaborators and how do you complement each other? Who is your statistician? What are her priorities? Who does your recruiting and counseling for trials? How are you incentivizing participants? Are you in danger of conflating race and genetic ancestry in your study? And who represents the future of your research? And where are they now? How can you start getting people into the pipeline for research as soon as and early as possible? I will also say that sometimes the work needs to begin with us and on us. A team that I helped lead was recently funded with a $6.5 million grant to fund the UPenn Prevention Research Center. And I'm the PI for the core research project. And what it is it's a provider level intervention that combines geriatric assessment with adaptation of the best case, worst case shared decision-making tool by Gretchen Schwartzy. And the idea is that we don't do a great job necessarily of weighing all the stakes that are involved when you meet an older person with early stage cancer. Sometimes the treatment is worse than the disease, and we need to be very careful that we don't compromise people's quality of life when we're offering them treatments. However, how do you assess quality of life? Again, like social determinants of health, we don't do a great job of making sure we really understand what someone's baseline health is, what their social support system is, what their baseline medications and comorbidities are when we first meet them. And so Beacon, which is the core research project study, is aiming to do that. We're hoping to combine routine geriatric assessment with knowledge about how to conduct best case, worst case shared decision-making counseling in order to hopefully improve the overall experience of shared decision-making for older adults with these diseases, as well as their likelihood of remaining on guideline concordant care and not having too much surveillance after diagnosis. One of the things that's really important here to realize is that the intervention is actually being done on us. We, the surgeons, are the ones who will be learning how to do this. And so again, it shifts the burden off of patients, assuming that they're the ones that have to be the ones acting towards improving the care that we deliver. And then finally, I want to conclude by just talking about how we can grow the next generation of surgeons and investigators. And again, I'm going to share a story. So in 2018, I had the privilege of presenting at the American Surgical Association. And it was interesting. I'd never been there. I didn't really know where to sit. If any of you have been there, you'll now know that basically the people who are moderating the conference sit on the stage. And you then at some point are called up to come stand at the podium. And I'd never been there again. I wasn't quite sure where to sit and was very, a little bit disorienting. But someone went right before me who presented a very interesting project. And as he finished, the moderators on the stage turned and said, and as expected, you ended exactly on time. And of course, I would expect that of you because of who your father is. So I thought about the fact that this is a situation in which the presumption this person was going to do a good job and that they're going to end on time was baked into their acceptance or their perception of him before he even walked on stage. And I was showing up, never having been to this meeting, not knowing where to sit, not knowing to stand. And I just thought about, again, if we assume the best of some, what by default are we assuming about others? And this can certainly contribute to a phenomenon that many people in this audience will have experienced, which is imposter syndrome. And I certainly had a healthy dose of that at that moment. It's an internalized sense of incompetence and not belonging, often associated with the fear of being exposed as a fraud despite objective measures of success. It's associated with burnout, it's associated with anxiety, and it's prevalent amongst our residents, especially general surgery residents. 76% reporting that they experienced imposter syndrome at some point over the course of their training. Now, about 5 years ago, after the ABSITE, two important surveys were administered to all of our residents across the country. One was the SNAC, which looks at people's experience of bullying, and the other was the MASLAC burnout inventory. And as is the case with ABSITE mandated types of responses, the rate was very high, with almost over 85% response rate, 7,000 responses across 300 US programs. 67% of our residents reported at least one episode of bullying behavior in the preceding year, and 44% reported at least occasional bullying. 18% reported frequent bullying, and these individuals are more likely to be women, racial and ethnic minorities, and people who had a history of doing less well on the app site. And notably, the most common source of these behaviors were our attending surgeons. It was us. We were doing this to our own. One in 30 of those who responded reported thoughts of suicide. And among those who reported frequent bullying, the rate was 1 in 10. Again, we're doing this to our own, and this is happening on our own family. How can we produce the next generation of surgeons who bring their best selves to work if we don't show them our best selves when we're training them and growing them into us? Not surprisingly, imposter syndrome, bullying are tied to who stays in surgery once we welcome them into the house of surgery. Again, from the same survey responses, we found that underrepresented in medicine residents comprised only 14 or 15% of all surgical trainees, but demonstrated a decrease in presentation and participation over time, over 20 years. Women were more likely to leave programs. Underrepresented residents were even more likely to leave programs. And Black residents had the highest attrition rates of all, 10%, as well as unintended attrition compared to white residents. And again, to realize that to make it to residency, you've already overcome a number of hurdles. You've already managed to demonstrate not only the intellectual and academic proficiency to be there, but also the social intelligence it requires to navigate spaces in which you are frequently the only or the first. And yet those are the numbers that we, surgery, had to report in 2019. It is important to see what you can be and to model what we want to have follow us. And so we can't underestimate the impact of demographic resemblance. That is the exposure to yourself early in your career of someone who resembles you and can model for you what you can be. We sought to look at that doing a study a couple of years ago through surveys that you may have actually received through various organizations. And we specifically wanted to see whether or not exposure at an early age to someone who looked like you might affect your likelihood of feeling like you belonged in medicine and in surgery, and also what your trajectory might be. And we found out of 6,000 respondents, which was again quite diverse with a large proportion of women, large portion of underrepresented minorities, is that women and non-white individuals were less likely to see someone who looked like them at a young age in the course of their training. But that early exposure, that is, if you did see someone who looked like you were much more likely to have a sense of belonging in medicine and also less likely to experience imposter syndrome. In addition, we found that being in a leadership position was associated with having an increased sense of belonging, not only in your medical specialty, but in medicine in general. So what does that mean? Women and non-white individuals are less likely to see self-resembling physicians at a young age, an association that's particularly pronounced for people of color. And holding a leadership position was associated with a decreased likelihood of having imposter syndrome and increased sense of belonging. Women were more likely to experience imposter syndrome than men, even among leaders, but race and ethnicity, as well as being URIM, we found were not associated with significant differences in imposter syndrome. Thus, if we help people feel like they belong, could they come to see themselves as leaders? And the reverse may be true. It could be that those with a proclivity for leadership often already feel belonging. People of color did not report more imposter syndrome than other groups, notably in our work. So this should not be used as an excuse for the inequities we see in representation amongst residents, faculty, and surgical leaders. We need to dig deeper and do more. And finally, I just wanted to share data from, again, something that you may have read, which is a really large study that we conducted looking at all of the general surgery programs across all of the United States, as well as Puerto Rico. We wanted to look at how you get to being a surgical leader. I think people often focus on surgical chairs. What is it to be a chair? How many chairs are there? How many women? How many Black people? How many Asian people? But there are many, many steps to getting to that point. And so what we wanted to do was look at what happens at the level of leadership just below being a chair. One of the things we found was that women occupied more vice chair roles than division chief roles. And what we also found is that certain division chief roles were much more likely to never have a person of color or woman occupying that role. In addition, we found that there were very clearly girl jobs and boy jobs, and very clearly Black jobs and white jobs, where there are certain types of vice chair roles, certain types of division chief roles that disproportionately went to one group or another. And the reason this is very, very important is that if any of you sit on selection committees for various types of positions across a university, you will know that a person's experience up until that point that they're applying for a job really shapes whether someone is considered to be qualified. And while divisions represent, you would say, a microcosm or a small version of a department, it is less clear how being a vice chair translates to being a mini departmental chair. And so if we aren't having equal representation amongst division chiefs, then we are very unlikely to then have equal representation among surgical chairs, given that we found that there's much more correlation between division chiefs and departments in terms of representation than there is between vice chairs and departments. It is also important to think about why there are certain types of roles that we've never seen a person occupy. And again, we have to think about how we're going to build the House of Surgery, promote equitable care and research if we aren't starting with who we put into these roles and how we equip them. Identity-based gaps in medicine and medical leadership, including surgery, persist. Imposter syndrome among minoritized groups may not be a significant contributor to underrepresentation, but it can't be ignored. It's not insurmountable. We have to do something about it while not using it as an excuse not to act. We can't be what we can't see, and power cannot simply be wrested from those who have it. It must be shared. Allies are important. We need to all want to see people who are not like themselves at the table, deciding who's doing research, elevating people into leadership, providing equitable care. We need to cultivate cultures of belonging, and we need to cultivate individual potential to lead, no matter who they look, what they look like, and where they come from. So, in conclusion, thinking about how to move towards a better version of our surgical selves, I'm going to come back to why surgeons. We are truth tellers. I think there's something about M&M that makes us committed to the idea that transparency is important and critical to our doing our jobs well. Dynamism defines us. We are frequently called upon to pivot in the OR, in clinic, in grounds, to do something different, do something better. And that is why many of us were drawn to surgery in the first place. We are drawn to doing things that are hard. If you told someone from outer space that you cut people up for a living and they let you do it, no one would believe you. It is an immense privilege that we do this, and we take it very, very seriously. We do things that are very hard, and we all want to do what's right. Furthermore, I think we all feel we have an obligation to be at the table in deciding how we care for our patients and how we can elevate our profession. Now, our world has been forever changed by forces that are viral, social, and political. We are actually incredibly privileged as surgeons. We have choices, we have options. And too often the people around us who do less well did not have those choices. And so I really feel that we have an obligation to take the wonderful options, to take the wonderful choices we have, and to do as well as we can with them. And think about moving towards a better version of our surgical selves. I would argue it is imperative that we lie at the intersection of resembling the patients we take care of, at advocating for their interests, and making sure their preferences and priorities are prioritized as part of the care we deliver. Thank you so much, and I'm happy to take any questions.
Dr. Fayanju, thank you so much for coming and delivering this. So my question to you, well, let me make a comment first and then a question. So the comment is that if the US government is really interested in decreasing costs, shouldn't we be addressing these issues and putting education resources where they belong, early detection resources where they belong, and proven therapies that actually match the patient population that we're taking care of. So, I know the answer to that, and that was really a comment. My question is, how did you take your great body and very successful work and pivot with all that's going on? And, for example, I'm the PI of a cancer center core grant, and I can't even use the word disparity in some sections, right? And so how, give us some examples of how you can carry on this important work, but still address the specific rules that the NIH, the NCI is imposing.
Thank you for both the comment and the question. So first of all, I think it's incredibly important during this time that we not comply in advance, and we know exactly what we can and cannot do. My understanding, because I actually serve on the study section for healthcare and health disparities, is that we can use the word disparity. We just can't use the word equity. We can use the word, there are a lot of words we can't use that's requiring us to really bring out our thesauruses and figure out creative ways in which to describe representation of groups, imbalance of social and genetic factors, et cetera. That exercise is obviously exhausting. You're already trying to do the work, and then you're also trying to use the language that may give that work a chance of getting funded. And I give a lot of credit to you and to others, including people at my institution, for doing the work of using the words that may help us get across the finish line. But words matter. And I do worry that there is just going to be a gradual and soon not so gradual erosion of any commitment to this work. I think in the end, we're going to have to rely on a lot of non-governmental sources. There are a lot of private organizations that are still willing to do this work. I think philanthropy is going to be very important during this time as well. Actually, I think partnering with industry, both device as well as pharmaceutical companies, who actually have huge areas devoted towards patient engagement, health economics, health equity. It's actually something that I think we're going to have to be very creative in terms of how we keep doing the work and saying the words when we can in order to make sure that we don't take our eye off of what's important. I would also argue that it's really important to look out for the people for whom this is all their work. Again, I actually do many different things besides work just related to health equity, and I'm continuing in that work, but there are people for whom that's literally their entire body of work. And the extent to which they are being driven out of academia, to which their livelihood, sometimes even their safety, is being attacked as a result of this time, cannot be underestimated and needs to really be something all of us should really prioritize in protecting those individuals. In the end, I think science will out, and I think that as we see a decline in outcomes that previously had been better, and we see a regression of America's place at the forefront of pushing science forward, I hope that there will be an understanding that we need to go back to the priorities that we've all had for many years, and this work can continue. And in the interim, we find diverse sources of funding to keep that work going. I will also say that we need to think about how, in the short term, we don't punish people in the promotion process because they may not be able to obtain the traditional metrics of success that previously were used. And I think that to the extent that people can keep doing the good science, even if they don't have all the funding numbers to go with it, that might be something we also need to be creative about as well.
Thank you.
Dr. Fayanju, congratulations on an outstanding presentation. What you just mentioned to Dr. Schulich's really exciting and thoughtful, especially about making sure promotions keep happening for people who've had their research stymied by the government. Thanks for joining us. Dr. Fayanju is the upcoming president of the Surgical Outcomes Club, which many of you hear about at our presentations, and I encourage you all to participate. That's a critical venue for health services research, development, and growth, especially for junior faculty. That's coming up at the ACS, and she'll be the president next year. So please consider participating.
Thank you. And he doesn't mention that he's also on the board director, so you have a great representative there as well. Thank you so much.
And again, we just want to thank you for your outstanding work and your outstanding presentation. We're really honored to have you here today. And we just wanted to present you with a gift from our department.
Thank you. Thank you.